Good afternoon, everybody. Like Jeff said, I am Dr. Lindberg, one of the physicians in the UAMS Department of Physical Medicine and Rehab team, and I'll get us started with today's talk. But because Dr. Dadal did an awesome job in kind of muscling hours and hours and hours worth of information into a 1 hour, hopefully concise, but I realize probably a little bit overwhelming lecture for you guys. I'm going to let her finish it up with the meat of the talk. So like Jeff said, today we'll be talking about guidelines for the management of altered mental status in patients who have had traumatic brain injury, and this goes from the acute traumatic brain injuries into the chronic traumatic brain injuries. It's applicable to all patients with this diagnosis. We will be going over the definition of altered mental status, especially in this patient population, because they are already altered from their injury. You do have to be aware of specific definitions for this patient population. We'll review assessment of patients who have traumatic brain injury with altered mental state, and then review differential diagnoses, so the different things that can cause this alteration in their cognitive status. And then review some recommendations for management and treatment, and then some prevention and education issues. Now, this is not terribly comprehensive, as you will know if you're in the medical field. Altered mental status is a huge differential, so we'll go over some of the most common things that can cause trouble in patients with traumatic brain injury, the ones that we see most frequently in the acute care setting and in chronic management of TBI. And so just for some definitions, so for altered mental status in general, it's just alteration in level of consciousness. This is objectively measured by the Glasgow Coma Scale, which is a scale that goes from 3 to 15, where 15 is functioning within normal limits. So anything less than 15, so anything less than that normal limits, is going to be alteration in mental status in just the general population of folks. This scale assesses eye-opening, best motor responses, and verbal responses. Another definition you'll need to know is level of consciousness, and this is patient dependent because this is affected by any kind of brain pathology or medications as well. So level of consciousness is the function of the pontine reticular activating system relating to both arousal, so that's your awareness of your surroundings and your environment, and cognition, which is response to various environmental stimuli. Now, neurological deterioration, this is really the big key in the definition for altered mental status in the brain injury population. So this is a decrease in your Glasgow Coma Scale score by 2 or more points. So it doesn't matter where you are on that scale or what your premorbid function is, it is a decrease in your score by 2 or more points. It also includes pupillary abnormalities, which can be fixed pupils unilaterally or bilaterally, anisocoria, mydriasis, slow or sluggish pupil response, focal neurologic deficits that are new or exacerbated neurological deficits. For instance, a patient with hemiplegia who has worsening in their strength and coordination, a patient with language deficits who has worsening in their speech intelligibility or worsening in their aphasia, and also in patients who are being monitored in the hospital. You can detect neurological deterioration by noticing increase in their intracranial pressure, usually greater than 15 to 20 millimeters of mercury, although this may or may not be accompanied by neurological deterioration. It is a sign that this may be coming. With neurological deterioration in the brain injury population, you can have one of two things happen. They can either become more cognitively depressed, which will show up as increased confusion, increased lethargy, obtundation, stupor, coma, worsening of neurological deficits, so worsening of their weakness, worsening of their language skills, or they may become elevated, and you often see this in the more functional of the traumatic brain injury patients, so the ones who are more ambulatory or more independent with their ADLs. In these patients, neurological deterioration may show up as hypervigilance, agitation, restlessness, insomnia, and sometimes seizure. And so do note that neurological deterioration is not just depression of cognition, but can be in a brain injury patient increase in adverse behaviors. So your agitation may become worse. And so for assessment purposes, history, just like with any patient who presents with any kind of medical change, needs to be fairly comprehensive, but especially so in the brain injury population. You do need to know what their pre-morbid cognitive function was baseline. You need to know the onset of the neurological deterioration, how long it's been going on, whether it's acute or not. The progression, is it rapid progression? Because that may put something more severe, such as a recurrent bleed or seizure, higher on your differential if it's a rapid progressing issue versus something that is slower in onset, which may indicate a hormonal issue, an endocrine abnormality. Anything that makes the behavior or the cognitive or neurological deficits worse. For instance, cognitive endurance is poor in these patients, and so if they've had a busy, hectic day or have overexerted themselves physically, that can cause some impaired consciousness and should get better with rest. You do also want to do a comprehensive medication review and get a good alcohol and drug use history, as those things can also influence your level of cognition. And so just some things, I won't read all of these, but some pertinent review of system findings might be fatigue, lethargy, changes in appetite, weight loss or weight gain, especially if you're thinking of endocrine issues. Again, with the neurological stage changes, mental status change, worsening of their present neurological impairments, such as increased tone and spasticity, increased weakness, visible seizures, dizziness, tremor, sensory loss, worsening headache, vision changes, chest pain, respiratory issues, nausea, vomiting, emesis may indicate that there's increased intracranial pressure, increased urinary frequency, urinary volume, urinary retention may also lead you to start considering normal pressure hydrocephalus or even a UTI. And then any skin changes can lead you towards infection or even endocrine abnormalities. And then as far as physical exam, this also does need to be comprehensive, as many things can cause neurologic changes in this patient population. Vital signs are important to show whether or not they're having hyper or hypotension, widening pulse pressures, hypoxia, hypothermia, which can indicate problems with intracranial pressure. You do want to record your GCS so you can note whether or not it's been decreased by 2 points at least, so they meet that neurological deterioration criteria. You want to do a comprehensive neurological exam as best you can with the patient's current level of impairment. See if the patient is posturing. Are they responsive? Do they have worsening ataxia or worsening neurological findings? Do you see staring spells? Do they appear post-ictal? Do you see new tremor? And then the rest of your exam, HENT, looking at their pupillary response. You want to do a good heart and lung exam. Skin exam is especially important in these patients, especially if you're considering endocrine abnormalities as well. And then as far as workup, and again, this is all inclusive, but it will be based on your differential. But a CBC is good if infection is on your differential basic metabolic panel, in case you're wondering if there is some kind of electrolyte abnormality. For instance, sodium issues are common, especially in the acute brain injury population. Your analysis, because UTI is one of the most common infections after acute traumatic brain injury, and that can result in cognitive changes. Blood cultures, lumbar puncture with CSF analysis, if you're worried about meningitis, serum and urine osmolalities, again, if you're worried about sodium impairments in these patients. Drug levels, serum and or urine levels, if you think that this is related to drug problems, or if a patient is on an anti-epileptic and it needs to be monitored. For instance, perhaps this could be Dilantin toxicity in a patient with seizure after head trauma. You do need to think about that. Thyroid function panels, liver panels, and then also neuroendocrine lab panels, which include your thyroid panels, prolactin levels, growth hormone levels, testosterone, insulin-like growth factor, cortisol, and ACTH, with growth hormone being probably the most common neuroendocrine problem after traumatic brain injury. And then as far as imaging, chest x-ray, chest CT, if you're thinking this is a pulmonary etiology, head CT if you're worried about recurrent bleed or new injury, or hydrocephalus, MRI brain, which is more sensitive than the CT head, and then an EEG if you are worried about seizure activity. And so, like I said earlier, in patients with traumatic brain injury, altered mental status can be defined as a neurological deterioration. It's not just change from that 15 score on the GCS, because a lot of times they don't have that full within functional limits GCS score. So it is neurological deterioration related to their baseline level of consciousness. And now we're going to move on to the differential diagnosis for altered mental status in the brain injury population. I'm going to let Dr. Dadal take over from here, and she'll finish us out.
Thank you, Dr. Lindberg. Okay, I'm going to go ahead and start with intracranial complications. Of course, this is the biggest concern that we have. This is what we have on our minds with the traumatic brain injury population. It is a broad topic and many things could go on, so I'll go ahead and start with intracranial bleeds, either worsening of the bleeds or progression of the bleeds or recurrence of the bleed. The incidence of intracranial bleeds, recurrence, or worsening in the mild TBI population is nearly 5%, and 5% of those had progression on repeat CT scans, so that would be worsening of their intracranial bleed. But after that, none of them developed neurological deterioration, so this is not really a very big concern in the mild TBI population. Of course, it doesn't mean that it can't happen, but it's very, very low on our differential. Out of all intracranial bleeds, it seems that subdural hematomas are the ones that are most likely related to worsening, and 23% of initially non-operative patients with subdurals require delayed surgeries. Those surgeries most frequently happened, 7% of them happened within the first 4 hours to 7 days. More than that, greater than double than that happened within the first week to the first month, and then back down to 3% greater than 1 month after injury required surgery for chronic subdural hematomas. The studies have been very clear on showing a correlation between the time from neurological deterioration to surgery as being significantly correlated with outcomes, versus there was no outcome correlation between time of injury and surgery. So it's very important to get that very detailed history about exactly when the neurologic deterioration started. 45 patients with brain contusions have radiologically significant progression. That is a very big number. Cerebral contusions tend to grow on recurrent CT imaging, 19% requiring of those requiring surgical intervention at a later time. And the time frame for deterioration for those brain contusions are usually between 5 hours and 4 days. The second topic after bleeds is seizures. This has been presented at a previous topic. Dr. Lindberg and Dr. McGuire presented the details on the guidelines of that management previously. After that is post-traumatic hydrocephalus. What is post-traumatic hydrocephalus? It's the dilatation of the ventricular system due to an imbalance between the CSF production and absorption, resulting from either insufficient absorption or production or blockage or overproduction of CSF. This can be either normal pressure hydrocephalus or can present as an elevated increased intracranial pressure. Incidence of this in the severe TBI population is about 14%. 25% present with either normal or increased pressure hydrocephalus within the first 2 weeks, 50% 3 weeks or greater, 75% within 8 weeks. So this is one of the complications that we're more likely to see at a later time. The incidence of hydrocephalus post-decompressive craniotomy is as high as 34.5%, occurring both before and after cranioplasty, so the chronicity varies. Only significant risk factor, other than having the surgery itself, would be the superior limit of the craniotomy being less than 25 millimeters away from the midline. CT findings of post-traumatic ventriculomegaly on any TBI patient can be as high as 80%. So in this case, it's very, very important to differentiate between post-traumatic hydrocephalus versus chronic sequelae of traumatic brain injury, such as atrophic ventriculomegaly, which would be a more benign finding in this case. So it's very important to look at the criteria for the CT findings for the post-traumatic ventriculomegaly. These criteria include enlargement of the temporal horns and the third ventricle in the presence of normal or absent sulci. But this criteria is not perfectly specific for hydrocephalus, and so to make the diagnosis of this, we do require a combination of the clinical deterioration or failure to improve and the neuroimaging to support it. Post-traumatic infarcts. The incidence of this is nearly 12% in the moderate to severe TBI patient. 30% occur within the first week, 42% 8 days to 2 weeks later, 14% 2 to 3 weeks, 7% 3 weeks to a month, and then 1 to 3 months is another 5% of people with brain injuries. Significant risk factors for having post-traumatic infarction is low GCS on initial score within the first 24 hours. It's also been correlated with low systolic blood pressures during the acute phase. Of course, brain herniation and decompression were also risk factors for infarcts. I'll move on from intracranial complications to one of the more common complications of causes of altered mental status in this population. I'll start with benzodiazepines, very, very commonly used in our TBI population, especially acutely in the ICU and chronically for anxiety, post-traumatic stress, and many other conditions. So we're definitely all more familiar with the side effects of these medications. Of course, they cause respiratory depression, prolonged sedation, especially the patients who have used Ativan or lorazepam, midazolam for sedation purposes. Long after the cessation of the drug, these drugs can linger in there and cause delirium and other complications. Barbiturates as sedatives, we use those a lot less. There's much better options out there, so we're seeing them a lot less. But in studies, we know that they have a long half-life and result in accumulation and prolonged sedation even after their discontinuation. And so we might want to frequently reassess the neurological status of these patients post these medications to make sure that we have an accurate baseline and we know where we start so we know where we're ending up. Opioid narcotics, again, we're very familiar with these medications. They do have all the same side effects that we know about. Ventilatory depression, sedation, hallucination, delirium, behavioral effects, seizures, accumulation tolerance, and a few studies have even pointed to a risk of an increasing intracranial pressure, especially with IV morphine being used in the acute state. Phenytoin, again, a little less used for seizure prophylaxis in this population, or overall in general. We have better things that are being used right now, but especially with the loading dose. This medication shows a significant impairment in cognitive function, specifically been studied in the TBI population, and it can have effects 1 month post surgery injury. Phenytoin toxicity is a pretty serious matter. It needs to be followed closely and corrected when it does happen. It is dose dependent, and it results in nystagmus, nausea, vomiting, ataxia, and many other CNS findings. The tricyclics is another class of medications that is frequently used in the population. They've been studied independently and have been shown to be less effective in the patients with the TBI and then in non-brain injured populations. And they do have anticholinergic effects and toxicity. And if these medications, of course, are able to cross the blood-brain barrier, they can cause anticholinergic syndrome, especially in combination with other medications that can cause this. And of course, this has a lot of altered mental status type symptoms. Lithium, another medication that we can see that has side effects of increased cognitive impairment, irritability, agitation, neurotoxicity, EEG spiking, and serotonin toxicity. We don't really commonly think about lithium and serotonin toxicity, but we really should, especially in this patient population. And with lithium, again, the adverse effects are dose dependent, and maybe correcting the dose or being more within the limits of the dose, so it reminds us to go ahead and monitor these medications. Serotonin reuptake inhibitors. Serotonin toxicity is the excessive serotonergic activity in the central and peripheral nervous system. Causes, of course, the clinical classic triads of altered mental status, autonomic instability, and neuromuscular hyperactivity. The intensity of clinical findings reflects the degree of serotonin toxicity, and when it's really severe, we term it serotonin syndrome. The incidence of this with patients taking this kind of medications can be as high as 18%. And what's very interesting about this is not only does it correlate with the degree of toxicity, the symptoms, they can develop pretty rapidly within minutes of ingesting the new dose, an increased dose, or within minutes of adding a new medication to the polypharmacy that you frequently see these patients on, that can alter the hepatic metabolism of them. Sertraline, in specific, may lead to a decline in both motor function and cognition, and an increase in number of post-concussion symptoms, including headache, irritability, akathisia, and insomnia. Interestingly, fluoxetine can have the unique adverse effect of affecting speech, and it can cause speech blocking and dysarthria. Buspirone side effects can include headache, which can exacerbate baseline headaches for our traumatic brain injury population patients, lightheadedness, dysphoria, restlessness, akathisia, agitation, irritability, and so on. The typical antipsychotics, another frequently seen, are frequently used in the acute population. And these have negative side effects on the cognitive and functional performance. They affect the duration of post-traumatic amnesia, time to cognitive functioning, and behavioral deficits. The typical antipsychotics are correlated with, although the pathophysiology is unclear, but neuroleptic malignant syndrome is something that we need to watch out for. It is a life-threatening complication where you develop muscle rigidity, fever, autonomic instability, and fluctuating levels of consciousness. It has a very wide range of reported incidents, from very low 0.2% to 12.2%. The fatality rate is estimated between 15 and 18%. That's pretty high. Many progress to seizures and rhabdo, resulting in multi-system organ failure, and so on. The atypical antipsychotics are slightly more used now than the typical antipsychotics, partially because of that reason of the risk of developing neuroleptic malignant syndrome. But although the incidence of them happening with this one are a little less, it is a risk. And clozapine in specific is associated with high adverse effects with CNS depression. Next on my list is infection. Research studies suggest that catecholamines released as a result of the brain injury induced sympathetic activation to protect the brain from further inflammatory damage, also modulate the cells of the immune system and induce systemic immunosuppression, increasing the susceptibility to infection. This is very interesting way for us to think about our patients in a way that they may be in some way immunocompromised as a result of their injury. The overall most common infection source in the traumatic brain injury population is a urinary tract infection, with an incidence of 20%. This is followed by pneumonia, septic shock, and intracranial infections are a little less than 1%. Approximately 50% of patients with severe TBI develop at least one infectious complication while in acute care, pneumonia is the most common of those, ranging between 41 and 74%. Diagnosis of infection is made in light of presenting clinical factors, positive culture of the infecting organism, or proof of an infection. Endocrine and glycemic control. My next topic includes the metabolism and endocrine complications or sequelae of traumatic brain injury that can result in altered mental status. Diabetes has been found to be associated with 1.5-fold increase in mortality compared to non-diabetics after correcting for age-related comorbidities. And avoiding insulin deficiency as well as hypoglycemia has been thought to reduce mortality overall in traumatic brain injury patients. Adrenal insufficiency. This is damage to the anterior pituitary gland, resulting in ACTH deficiency, causing secondary adrenal failure. Consequences of this acute glucocorticoid deficiency after traumatic brain injury are potentially fatal, resulting in life-threatening hyponatremia and hypotension that requires vasopressor support. The incidence of ACTH deficiency within the first 2 weeks after traumatic brain injury is between 4 and 78%. Again, very wide range there, so it's something that we have to keep on our radars. Neuroendocrine complications, post-traumatic hypopituitarism. Hypopituitarism has our information that we get from this. We collected this body of information from neuropathological studies, and many of them have shown trauma to the pituitary, resulting in lesions to the pituitary capsule, the anterior and posterior lobes, the pituitary stalk, hemorrhage, infarction, necrosis, and fibrosis. Prevalence in severe, moderate, and mild TBI, respectively, are 35%, 10, and 16% of developing hypopituitarism. Prevalence in the chronic phase after a traumatic brain injury is as high as 27.5%. Risk factors for post-traumatic hypopituitarism include increased cranial pressure, long ICU stays, DAI, and base of the skull fractures. Diagnosis is often missed or delayed with potentially serious and life-threatening consequences, likely because of the subtle presentation of the problem. And most of the signs and symptoms have considerable crossover with the sequelae of TBI, including fatigue and memory impairment, emotional lability, behavioral disturbance, and so on. Central diabetes insipidus is defined as the decreased secretion of antidiuretic hormone from the posterior pituitary gland. Diabetes insipidus is well recognized in the acute phase after TBI. It's associated with a higher level of head injury, cerebral edema, and higher mortality rate. Incidence in moderate to severe TBI is up to 26% in the acute phase and 7% in the long-term survivors. 78.5% of acute phase diabetes insipidus is transient. The median onset is 6 days, and the median duration is 4 days. The diagnosis or the hallmark of diabetes insipidus is a very large urine volume of 3 liters a day, greater than 40 cc's per mg per day, and with a urine osmolality less than 300. This is in contrast with the syndrome of inappropriate antidiuretic hormone and cerebral salt wasting. These two syndromes are the most common cases of hyponatremia in the neurosurgical population. Hyponatremia and inappropriate correction of hyponatremia is associated with a very high mortality and morbidity and mortality rate, including severe edema, mental status changes, seizures, vasospasm, and of course, pontine osmotic demyelinating syndrome. The median onset is 3 days. It's almost always transient and unrelated to the severity of the injury, which is an interesting point here. Obtaining hormone levels of the ADH and natriuretic peptides have not been supported by the literature, neither for diagnosis nor for prognosis. I'll move on to the management and treatment recommendations based on topic. Intracranial complications first. First thing we want to do is prompt recognition of the neurological deterioration. An appropriate clinical assessment is essential, starting with the GCS and moving on. After that, it's very important to move on, and if we do suspect an intracranial process, get them to a CT scanner, CT head without contrast. This is the gold standard in the acute neurological deterioration and the most studied diagnostic and prognostic criteria. And the subacute or chronic phase, MRI is recommended because of its ability to look at the soft tissue structures and the progression of some of the cerebral pathologies. Other causes of altered mental status definitely need to be considered, but if the intracranial complications is high on our differential, then we need to obtain urgent neurosurgical evaluation. Management of the acute neurologic deterioration, more than 2 points on the GCS, pupillary changes, or raised intracranial pressure in the traumatic brain injured population. Of course, we have to start with the ACBLS protocols with the circulation, airway, and breathing. We must maintain very strict hemodynamic stability with a goal of systolic blood pressure at least above 90 using fluid resuscitation. We have to monitor pulse oximetry very closely and maintain saturations greater than 90% to avoid exacerbation by anoxic brain injury. Hyponatremia that is not corrected with supplemental O2 or a GCS less than 9 absolutely warrants either bag mask ventilation or advanced airway intubation. Hypotension and hypoxemia are statistically independent predictor factors of outcome due to the effect of oxygen on delivery to cerebral perfusion pressure, and the equation here is mean arterial pressure minus intracranial pressure. Continuing management of acute neurologic deterioration. When the patient is developing signs of impeding cerebral herniation, we can utilize brief periods of hyperventilation therapy of 20 breaths a minute for a PaCO2 goal of less than 35 as a temporizing measure, and then stop this measure immediately when the clinical signs of impeding herniation resolve. This can be used an infinite number of times, but with very, very caution to watch the clinical signs very closely in order not to overutilize this method. Patients with signs of progressive neurological deterioration referable to the intracranial lesion that are, of course, medically refractory to intracranial hypertension requires immediate CT scanning and neurosurgical evaluation. Pharmacologic complications. The mainstay of management here is immediate discontinuation or tapering of the offending medication and supportive treatment of symptoms. And the mainstay of treatment in a withdrawal situation is implementation of appropriate taper and supportive measures. Serotonin toxicity and syndrome. First-line management, of course, is withdrawing the offending agent and supportive care with external cooling and hydration. This is usually, the first-line management is usually sufficient for the treatment of mild toxicity, which usually resolves within 24 to 72 hours. In this case, if you work with the traumatic brain population enough, you will get the call that this patient is having increased spasticity both, and using antipyretics such as acetaminophen or nonsteroidal anti-inflammatories has not been successful in decreasing their fevers. This is definitely a signal for us to think about serotonin toxicity. The antipyretics do not work in serotonin toxicity because the hyperthermia that results is secondary to the muscle rigidity rather than the hypothalamic temperature set point. Benzodiazepines can be used for symptom control, symptoms such as rigidity, agitation, and tremor. For moderate to severe symptoms, including times when there's hypertonicity, hyperthermia, autonomic instability, or progressive cognitive changes, these patients are going to require hospitalization, close monitoring. The use of serotonin 2A agonist, cyproheptadine, has been used as an antidote and is recommended as treatment for the moderate to severe serotonin toxicity with the following doses. Alternate methods, less sedating antidotes do exist. The chlorpheniramine is an alternative. However, in this condition, the use of propranolol, bromocriptine, or dantrolene are not recommended, and they can result in hypotensive shock, exacerbation of symptoms, or have no effect on survival. Severe hyperthermia and muscle rigidity warrant neuromuscular paralysis, sedation, and possible intubation. The typical and atypical antipsychotic toxicity in neuroleptic malignant syndrome. Management of this starts with, of course, immediate discontinuation of the dopamine blocking agents, the rapid initiation of supportive measures to include, of course, volume resuscitation and external cooling, and the use of benzodiazepines for symptomatic control. Centrally acting dopamine agonists, like the bromocriptine and amantadine, have been utilized successfully and are recommended in the cases that fail to improve with just supportive care, but the validity on those is still limited. In severe cases, the use of dantrolene is suggested alone or in conjunction with dopamine agonists to relax the skeletal muscle, with starting doses, maintenance doses, and so on, clearly defined in the guidelines. Symptoms of this usually resolve within 6 to 10 days, but the treatment needs to be as long as the symptoms are present. Infectious complications. Antimicrobial therapy, empiric anti-infective therapy. This is indicated in patients that meet SIRS or sepsis criteria, to include one or more drugs that have activity against all likely pathogens and adequate penetration into the source tissues. The antimicrobial regimen should be reassessed daily for potential de-escalation to the most appropriate single therapy as soon as the susceptibility profile is known. Empiric broad-spectrum antibiotics should not be used more than 3 to 5 days. It should be de-escalated after that. The use of low procalcitonin or other biomarkers that are similar is recommended to assist in the discontinuation of the empiric antibiotics in these patients. And duration of therapy overall typically should last 7 to 10 days and no longer. Longer, of course, in very selective cases, such as Staph aureus bacteremia, semifungal, and immune-compromised patients. Antimicrobial agents should not be used in patients with severe inflammatory status, and that is determined to be of non-infectious causes, such as steroid-induced leukocytosis. Source control is a very important part of the management and treatment of infectious complications. A specific anatomical diagnosis of the infections, if infection requires consideration for emergent source control, be sought within the first 12 hours after the diagnosis. When the source control is in a severely septic patient is required, we should use the least invasive method for drainage. Intravascular access devices are a possible source of sepsis. They should be removed promptly. Prevention, this pertains mostly to ventilated ICU traumatic brain injury patients. The use of oral chlorhexidine has been recommended to prevent pneumonia, peri-procedural antibiotics for intubation, and early tracheostomy within the first 4 days to a week to reduce mechanical ventilation days. Ventriculostomies and intracranial pressure monitors be placed under sterile conditions and left to drainage without being exchanged frequently. And furthermore, there's been no support for the use of antibiotics for prophylaxis for greater than 24 hours. Endocrine and metabolic complications. Hyperglycemia, definitely a frequent cause of acute traumatic brain injury complication in both diabetic and non-diabetic or not diagnosed diabetic people. Routine monitoring, ACNHS or Q4 is highly recommended and has been established as the standard of care. Many research studies have looked at intensive insulin therapy. This is a way of managing very strict normal glycemia. But this has been shown remains to be controversial. It has not shown to have any superior benefit when it comes to mortality. And it has been shown to increase the risk of hypoglycemic episodes, which are independently related to outcome. Correlation with low to moderate sliding scale, insulin therapy and hypoglycemic control, which are the basic protocols for the hospitals that we have now, are both safe and effective in this situation. Adrenal insufficiency, close monitoring of the signs and symptoms of hypocortisolism is very important, and we need to watch out for the hyponatremia, the hypotension that is resistant to ionotropes, hypoglycemia, and unexpected slow recovery. Acute phase, the first week of injury, in moderate to severe brain injury. Again, the guideline does condone daily monitoring of the serum cortisol levels for the first 7 days of injury, with less than 200 millimoles per liter requiring a stress dose of glucocorticoid replacement, and values between 200 and 500. If they're showing symptoms of adrenal insufficiency, then a trial of the glucocorticoid therapy should be considered. In the chronic phase, the insulin tolerance test is used for the standard to check for growth hormone. This is contraindicated in the acute TBI population with cardiovascular or uncontrolled seizures. So there are alternatives to that test. Central diabetes insipidus, the acute phase, a hypotonic polyuria association with the presence of the hypernatremia and/or elevated plasma osmolalities. This warrants the trial of injection of sub-Q or IM DDAVP. Immediate hormone replacement with desmopressin and hypotonic fluids is guided by the urine output and the plasma sodium. In the chronic phase of diabetes insipidus, formal evaluation can be used using a standard 8-hour water deprivation test, and this can be maintained with oral desmopressin. SIADH and cerebral salt wasting within the acute symptomatic hyponatremia, less than 48 hours. Correction with hypertonic saline 3% to raise the plasma sodium, no more than 10 milliequals per day. Should be followed by chronic correction guidelines. Chronic correction, greater than 48 hours. Correction should be no faster than 0.5 millimole per hour to avoid the risk of osmotic demyelination. Finally, prevention and education. Prevention and early recognition is the most important thing when it comes to altered mental status. Education of the caregiver and the patient on common complications after the traumatic brain injury is essential. Early detection of intracranial, pharmacological, infectious, metabolic, and endocrine-related complications that may result in altered mental status. The use of the smallest effective dose of medications for the management of pain, spasticity, mood, behavioral issues, and seizures. Routine follow-up with the medical team that is familiar with the metabolic and endocrine issues that may occur after TBI is very important for monitoring and early detection of complications. This PowerPoint is meant to be used in conjunction with a PDF profile. Please refer to the complete guidelines for full details and references.